So I've noticed a trend in disparities between BLS and ALS levels during appropriate escalation. So what I mean is that when you have patients who get a call out basically, and it is a BLS call and you are in an area in which you have BLS specific ambulances, I find that there is not escalation to the level that needs to be oftentimes when it's a double EMT truck. And why that matters realistically is because then we are not able to offer the patient the level of care that they need, and then we are often delaying the actual appropriate care that needs to happen. And at an ALS level, oftentimes, if it's a double paramedic truck, I say you, but I find that there is proper escalation because you have two higher level trained people in the back of the ambulance or wherever dealing with the patient. But oftentimes when you have two EMTs, they are not escalating appropriately, especially when it comes to traditional symptoms. So say you get a call out for, MSS, right? And you get blindsided, oh, this is a BLS call, it's MSS, right? And the patient initially presents with just MSS, right? And you're like, okay, no big deal. But en route, the patient's emesis, right, continues. And then on top of that, they start presenting with secondary symptoms that are not traditional to just hyperemesis, right? So we're seeing the patient has increased confusion. The patient has decreased oxygenation levels, right? And now you could say, okay, cool, they may have a decreased oxygenation level because they are vomiting. Okay, yeah, sure, I can see that. But if your oxygenation levels are trending downwards and you aren't choosing to escalate even just to putting, a nasal cannula in, all right, that's your choice. But realistically, that's one way that we can kind of see, is it just, right, the patient is now increasingly more confused due to hyperemesis, and that hyperemesis is causing the oxygenation level to decrease because they just can't stop vomiting? Or is it they're vomiting because there is actually something else going on, and that hyperemesis is not actually a initial presentation of it, but a secondary symptom to what actually is happening inside of the body? And this is why it's so important when, I've actually made jokes about this before, about pay to pass EMT schools, because what they're doing is they're pushing out these EMTs without actually going into the, pathophys of the body, basically. And so then we end up with these patients coming into the ER, and they are presenting and they're being called in as, oh, it's just emesis, right? But then the patients are presenting and we're seeing the secondary issue of, confusion, decreased oxygenation. I would even go as far to say as sometimes patients are having tachycardia associated with this. And right, in the short term, at a BLS level, if we're not looking any deeper into why this patient is doing this, I can see where an EMT at a BLS level would just say, oh, these are all secondary to the hyperemesis. But are we asking ourselves, especially in a pre-hospital setting, if you're working in a double EMT truck, is this hyperemesis the epicenter, or is this hyperemesis a secondary symptom of something else? Right? And if we think it's something else, are we then expressing that when we get to the hospital, or are we just foregoing that and being like, well, they'll run tests and they'll figure it out? because, as you know, there are certain things that need to happen in order for that patient to get the diagnostics that they need. There's blood to be drawn, there's, orders to be placed, and those things can overall decrease the patient care level and increase the chance of mortality or injury to the patient that's already sitting in a hospital. And the reason we have EMS, as you guys know, if you've taken any EMS courses that are legit, that there's an EMS history involved. And we know that EMS was set up a good portion of the time to be that initial middleman before a patient is getting to the hospital, so that they're getting appropriate interventions and that we are hopefully sustaining life longer. And that they can then leave the hospital with a better outcome overall. And I really think that as, practitioners, we need to be talking to newcomers, regardless of age. If they're new to being EMTs, we need to talk to them about proper escalation in EMS, because if we are not looking deeper than just what we're being presented with, we can often miss big red flags because we're hyper focused on the symptom that's being presented to us. We're going to be looking at those deeper lines down, and we're going to be making these, assumptions based off of that and treating appropriately. But at a BLS level, I feel like oftentimes we don't teach our EMTs to appropriately then look deeper than what the symptom is initially. And then we end up with these patients who are presenting to the ER, and 2 to 3 hours later, we are finding that there is actually something deeper going on that is causing this hyperemesis that could have been escalated appropriately initially if we would have had the information, or at least had we could have made the assumption that there is something else going on. And I say all this only because there are studies that have come out that are going to be in the symposium for next January. I say next January. I really mean January 2024. And a lot of them are talking about appropriate escalations pre-hospitally, and then the long-term outcome of the patient once they leave the hospital. And if I can find it, I'll put it in the comments again. But if I can't, it is what it is. Google it. But there really has to be a deeper conversation, especially at our private levels, because I feel like specifically at the private levels, it's so corporatized that we're not really looking at the true point of pre-hospital emergency medicine, which is, again, to kind of mitigate any of those potential issues so that we can get the patient the appropriate level of care that they need and not be triaged, or not be then, put in a regular room when they need to be in the state room. Right? Or if they need an emergency CT or MRI, once they arrive, they are getting to those things in an appropriate manner, versus then, 2 to 3 hours later, the doctor's like, oh shit, this might actually be going on, and then making that, hard right turn to actually get them the level of care that they need. And I just want to start the conversation. I know a lot of people, don't really go in depth with this stuff, but I think that this needs to be a conversation that happens regularly, and like I said, especially in the privatized world of EMS, because we're missing steps, and we're actually having detrimental patient outcomes because our lack of ability to escalate appropriately at a BLS level. I don't know. Have a good day, guys.